So, next on the agenda is a discussion on biliary drainage. This might be perceived as perhaps not a terribly important point, but you could hear from the prior speaker at the end of the last session that something as simple and straightforward as biliary drainage can be absolutely transformative to patient care and can lead to lots of additional therapies. So I'm very pleased to introduce Steve Damink, who's one of my ex-colleagues, who has actually been very influential in the discussion and the evaluation of the literature related to biliary tract drainage in cholangiocarcinoma. So I'm delighted that he's come to share his thoughts and views on where we are with biliary drainage for cholangiocarcinoma. Thank you very much indeed, Steve.
Thanks. So thanks for the organizers to invite me. I've met Helen last year during an ENCCA meeting. So if I look around in the audience, I think it's a mix of medical specialists and a mix of patients and scientists. Is that correct? So there are also a lot of non-doctors here. Is that correct? Good. Then I will adjust my talk a little bit so that the importance of what Mr. Roger also told us about the delay in his treatment can also occur for something we think that we should do. And I hope at the end of my presentation I convince everybody that we should really think if we should do it. And I don't think that we should do it for all patients. Because sometimes I think it's important to drain. Let me get for the next slide. There we go. So with hindsight, I should have shown you a slide of a paper of 2019 of Robert-Jan Koenen that shocked the Dutch, and we are still in shock because it appeared in the Lancet, Gastroenterology and Hepatology, and we thought, let's look at which drainage procedure should we do. Should we do it percutaneously or via an ERCP? And we finished it. We didn't finish it. We stopped after 43 patients because we had 10% mortality in the percutaneously drained patients before even going into surgery. And after surgery, that even went to 40%. And these data are seldomly presented in the literature. So we don't have data of all patients that arrive, and then you go into a trial. So that is the Robert-Jan Koenen paper in 2019. In which we showed that a lot of the patients don't even reach surgery. Then if you look at the reason that we drain, is probably because we had invasive technology to really think about where the tumor is and to align the different segments. So we had to go in with a catheter and then make a cholangiogram. Daniel Cherki challenged this. And this is, I think, a seminal paper in which he presented his data of 20 patients prospectively, and he said, I don't do it. The only thing that I do, if I look if the patient is fit, we make a CT scan, and then intraoperatively, I decide if I can resect. So I don't touch the liver because the liver is sterile. And of the 20 patients that he operated, the biliary system was sterile, so no bacteria in the biliary system. And he compared it to his control group of his own center in which people had normal liver function, but also an extensive operation. And he could show that under circumstances, he thought that you should not drain a patient. And these will be also on my final slide. So I think Daniel Cherki really challenged what we should do and advertised what we should do. And as you probably know, that the things that are advertised don't always end up in your plate. So it's not what you get. This is a patient of this year to Maastricht University. Maastricht is a very tiny university. It's the south of the Netherlands. But it's very renowned of the metabolic research. So I'm partly in Maastricht and partly in Essen, in which we are a very high volume of cholangiocarcinoma, almost resecting 80 patients a year. So this patient was seen in a different hospital. They are discussed in an MDT with up-to-date knowledge, And then it went into drainage sessions, and at the end of the day, because of all the complications of the drainage, we couldn't even operate this patient, and the patient ended with best supportive care. So the incidence is also in the Netherlands. These are Dutch numbers, 2020. It's the incidence of biliary tract cancers, the bile duct cancer, but also gallbladder cancer, and the survival is poor, and there is not a real advantage. And in the Netherlands, it also is important if you attempt to resect the tumor. If you don't resect, you die earlier. That's what everybody knows. But it's even in this tiny country in which we don't have private practice and we're very highly organized and do all kinds of, collaborative studies. Even in the Netherlands, it matters if you are firstly seen in a teaching hospital or in an academic hospital or in a general district hospital. There's a real survival difference. And it is also shown by the resection rate. Because of the low incidence, we in the Netherlands only resect 45 patients with the perihilar cholangiocarcinoma. That's the same volume as in the Essen unit I work. So within one German hospital, we do as many operations as we do in the whole of the Netherlands. So you have 5 hospitals, I think, at the moment in which we do these resections. So the caseload is actually too low, I think. We need to go for centralization because it really matters, where you end up. In a regular hospital, the resection rate is 13%. In an academic, it is almost 1/3. And not all patients are directly referred to an academic hospital. So there is a plea for getting higher volumes, get dedicated centers that really pay attention to this difficult disease. So the initial drainage is key. So when the initial drainage is performed without complications, the patients are operated have a longer overall survival. So this is an Italian paper that really showed that if the initial drainage procedure failed, that you have a overall survival odds ratio of almost 3, so 2.7, so a poorer survival. So it really matters that the initial procedure is really done with the best possible, in the best possible way. This is the Dutch cohort. That's a cohort of 10 years in which we registered everything that we did, and you can actually see that the successful drainage procedure percutaneously is 1/4 or 24%, and that via an ERCP, so an endoluminal drainage, is successful in the initial drainage, almost half of the patients. So even in a relatively, high-end healthcare system, less than half of the patients are initially drained without complications. This is a very interesting novel approach, also by Bas Groot-Koerkamp. So Bas was educated in the Netherlands, in Amsterdam, and then went to Memorial Sloan. There he picked up the pump study, but in Memorial Sloan they did also something else. They placed the stent percutaneously in the liver, but didn't pass the ampulla, so no connection with the GI tract. And that was picked up by the Memorial Sloan doctors from Amsterdam in 1988, where Lameres published this non-papillary passing way of stenting the tumor. So you go in with the puncture, go to the liver, cross the tumor, place the stent, glue the tract, and that's it. So he came back from Memorial Sloan and introduced Tesla. At that time, Tesla was still, a thing that you could advertise as being progressive and good for the environment and other people. So we need to change that name, unfortunately, I think. But here you can see that it's Dutch. The galweek-kweekuitslag is actually how many bugs you saw in the bile. And they had a 95% clean, sterile bile. I think that's the key. Because after the resection, we lose sometimes patients within a couple of days because there's overwhelming sepsis of the bacteria that are still in your biliary tree, in which we want to place stents to get it out preoperatively. So I think what he showed here is very important. and even important in the palliative setting, because this we didn't do it prospectively for the surgical patients, but these are patients with the non-papillary crossing stent, as we call the Tesla trial, and you can see that there's a survival benefit in the palliative setting if you place a stent, but don't contaminate your biliary tree. So it's a huge benefit for people that are palliative. And what we did, the right-hand side, that's what we started in Maastricht, let's use it up front. Difficulty is that you don't have a diagnosis made by histology, but we published this case as that it can also be very quickly done. Patient was admitted to us 28 days, and we did a resection, and at home 28 days with a CRP that never was above 10. Is it always necessary in perihilar carcinoma? This paper is under review. I used a data set that was initiated by Bas Groot-Koelkamp and Pim Althoff, 27 large centers that treat perihilar carcinoma in Europe and in Asia. So we lumped all the data together, and then we looked at who was drained and who was not drained. So you can see that quite some patients were undrained, and so probably people adopt the strategy that was advertised by in the beginning of this century. But to really do it scientifically, what we attempted is to balance the two groups. So you have patients that are drained, but it was not prospectively, so you need to have a clever statistical approach to try to mimic the two groups, the drained ones and the non-drained ones. So we use propensity score weighing, in which we used the complete data set. So we didn't match or invented data, so it was really based on the patients in the cohort. So you can see that initially we had a little bit more than 2,000 patients at the left-hand side, at the right-hand side. You can see that based on this weighing of the propensities that a certain factor is in a group, you end up with the artificial 2,000 patients. But most importantly, you see that there are differences. In the non-propensity corrected study group, you see a difference in mortality under undrained. So the more people survive if you do not drain them. That lost significance. It's 0.1, so 10% chance of having it by chance. If you drain the patients. So undrained has a trend to have a better survival. But clear data show that you have less post-operative complications and less post-operative liver failure in the group that you don't drain, which makes sense because there are no bugs in the liver. So you can present it. This is the 90-day mortality. Before we did the weighing, there was a significance. After the propensity weighing, that disappeared. But here, the major complications was still significant, and also the liver failure was significant. So if you don't drain, it's probably better for the patients. Of course, there are limitations. It's multi-center, it's not prospective, different resections, different perioperative workup, different antibiotic protection. But at least the data show that it's not worse. So it's not worse. I think it's better in some cases to don't drain, but at least it's not worse. So these are the conclusions. So the draining procedure might be of importance. That was neatly shown by Daniel Cherki. We do it, and I think it's based on the fantastic data of the Japanese in the 1990s, 2000, in which they used the perioperative cholangiography or the preoperative cholangiography that gave infection in the biliary tree. Therefore, we had to, drain it. But if you avoid this invasive procedure with nowadays scan, CT scan, MRSRP, and whatever, diffuse weighting, we probably don't need this. So our ambition is to really test the statement of Daniel Cherki made 25 years ago in a prospective trial. I got some German funding to do a prospective trial, and this is the draft of the way we want to test this in a prospective way from the start that the patient is admitted. So even making also identifying the patients that are eligible or that we can work up going into the resection, and not only as what has been done in the last 25 years, only look what happens after the resection, because sometimes you lose these patients. These are my acknowledgements. So central in the presentation and central in Maastricht is Maxime de Wulf, who's a junior surgeon trained by Ulf Neumann, probably in Europe one of the higher volume surgeons, and they really form a team that try to establish dedicated surgeons for this perihilar problem. And of course Bas and Pim Olthoff, who work on this problem for the last couple of years. Thank you.